let me pass you.
Oh, thank
Gotcha.
you.
All right.
When you're ready, I'm going to do a very quick introduction. Yeah, thank you everybody for coming, and thank you for people who are watching this online as part of the recording. My name is Ray Sheen. I am on the student council, and this is the second of our 5-month speaker series. We have with us Jeff Day, who is a nursing practitioner in the New York City for 11 years, and he's going to be speaking on gender-affirming care for intersex persons. So now, let's welcome Jeff Day. Thank you very much.
Great. Thank you so much, Ray. I appreciate it. Did I get the name right? I messed it. No,
That's
it is
Ray.
Ray. Okay,
Yep.
sorry. I wanted to be sure. Thank you. I appreciate the very kind introduction. Thank you to Patrick Robinson. Hello. Thank you to Patrick Robinson, who is Vice President here at Pacific, for suggesting that I be a speaker. A special thank you to the Student Council, as well as to Diversity, Equity, and Inclusion. I think it goes backwards here. Equity, diversity, and inclusion.
Diversity and
Okay,
inclusion, yes.
Got it. It's a little different in the school I work at, but thank you nonetheless for inviting me to be here today. I appreciate it. And so we'll be talking about affirming primary care for intersex people.
Can I just say, I'm Dana, I'm chair of the Equity,
Oh,
Diversity, and
great.
Inclusion Committee. However, I have a clinic shift, so I can't stay.
Mhm.
But I did just want to come and acknowledge and be, have EDI represented at
Oh,
some
that's very
point
kind of
here.
you.
But I'm sure I'll see, it's being recorded, so I'm sure I'll see the talk online, but enjoy everyone.
Thanks so much,
Thank
Dana.
you.
Have a great evening. So much of what I'm going to be sharing about today is care of the LGBTQIA+ Health Education Center. It is an education clearinghouse that's put together by Fenway in Boston, Fenway Health. I don't know if any of you are familiar with Fenway Health. It's the premier LGBTQ+ care in Boston, Massachusetts. And if you're interested in learning more about this topic, you can go to lgbtqiahealtheducation.org. And there is a wealth of information about queer health on Fenway Health. Just a quick poll. It's a little tricky because we have just a few people, but how many of you know, at least on a scale of 0 to 10, about a 2 or 3 about intersex people? Perfect.
When you say intersex, can you clarify?
I'm about to. Yes, I would be happy to clarify. You're going to learn all about it. That's great. My hope was that there would be a dearth of knowledge about the topic, so that I'm not talking above anybody's head or below anybody's. So I look forward to sharing with you today. I want to tell you a little bit about me to begin. So I'm formerly clinical assistant professor at NYU here in New York City. Taught there for about 7 years. Used to teach or formally lectured on gender-affirming transitioning care, so hormones for trans patients. Also taught in pathophysiology as well as pharmacology. So I did a few things there. Lectured on HIV as part of my duties, and towards the end of my tenure at NYU, I put together an LGBTQ+ health elective course. So for those students who were interested in that topic or more interested in that topic, they were welcome to join the elective towards the end of their time at NYU. It was quite rewarding, and fortunately the course goes on. I continue to teach as an adjunct at NYU, so it's still available for students who are interested. Currently, I am at Callan Lord. Who's heard of Callan Lord? Anybody? Great, thank you, good. Callan Lord is the Fenway of New York City, so we're the premier LGBTQ+ healthcare here in New York City. Of course, there are other folks who take care of queer people, but I'm partial to Callan Lord because that's where I work. I've been there for a little over a year now, so I'm still getting my feet underneath me, but it'll take a little time. In addition, I am the chair of the nursing section of GLAMA, formerly the Gay and Lesbian Medical Association, which we now call Health Professionals Advancing LGBTQ Health Equality. Our conference this year is in Charlotte, North Carolina. It's going to be in October. So if you are particularly interested in queer healthcare, that would be a great place to go. And I've put in my plug now for Callan Lord and Glamma, and I can move on with the topic. You asked a very good question. What is intersex? So let's discuss. First, I want to highlight the differences between sexual orientation, gender identity, and sexual or sex development, because there's a very big difference in those three. The first, which many of you may know, sexual orientation, or how a person characterizes their emotional and physical attraction to the same and or other gender, so to whom you're attracted. Gender identity, a person's inner sense of being a girl, woman, female, and there is other terminology that could easily be put in there. I kept it succinct for time. Boy, man, male, or something else. So first, who you're attracted to, gender identity, who you are at your core. And what we'll be talking about today is intersex. And intersex is a range of variations in sex characteristics and development. And intersex can be broken down into a few different categories, and I'm going to explore them individually, but I'll share with you the titles now. Other names, ambiguous genitalia. You may have heard ambiguous genitalia used in the past. Another is disorders of sex development. A third is differences in sex development. And it's people in the community will use different terminology. And by community, I mean those who are intersex, those who practice in intersex care. Many use different terminology. One that is old and is absolutely no longer accepted is hermaphrodite. You may have heard that terminology before. Just as a definition, for those of you who may not have heard of that, a person or animal having both male and female sex organs or other sexual characteristics. Its origin is Greek. Hermaphroditus, I believe it was, the offspring of Hermes and Aphrodite. Part of the reason it's no longer accepted is it's just plain not accurate. We're not talking about folks that have both female and male genitalia. You'll learn that it's something very, very different from that. So hermaphrodite, no more. It's considered obsolete, it's offensive, and we don't use it. So I'd like to break down the definition of intersex from 4 different resources, different angles, and I'll point out how they're different in just a moment. The first is a clinician's guide to gender affirming care, and they define intersex as a term describing people who have physical sex characteristics, that is chromosomes, genitals, and or gonads, that are not considered typical within the binary framework of male, female. The second, and I'll make these available to you so that you don't have to feverishly write down everything. The second is Medline Plus. Intersex is a group of conditions where there is a discrepancy between the external genitals and the internal genitals. And by internal, we mean the testes and the ovaries. Then I look to Intersex Society of North America, who defines intersex as a general term used for a variety of conditions in which a person is born with a reproductive or sexual anatomy that doesn't seem to fit the typical definitions of female or male. And then the final definition I pulled from Planned Parenthood. Planned Parenthood defines intersex as an umbrella term that describes bodies that fall outside the strict male-female binary. So you'll notice that there are very clear similarities between the different definitions, but there's a distinct difference as well, and I want to point that out. So the first describes people, right? The second describes conditions, the third conditions, and the fourth bodies. So in that way, we're coming at it from a different edge. Are we talking about the people themselves? Are we talking about their physical bodies? Or are we talking about conditions? And those conditions I'll talk to you about in just a moment. So let's look at some common intersex condition categories. The first, ambiguous external genitalia. The second, lack of responsivity to sex-related hormones. 3, inconsistency between external genitalia and reproductive organs. And then 4, chromosomal variants. And I'll tell you, there are about 40 recognized different variances so I'm not going to be able to tackle each one of them tonight. But just to let you know, it's a large number of variations. So, some common intersex conditions. Let's talk about them individually. The first being ambiguous external genitalia. That can refer to clitoromegaly, which is a large clitoris. It can refer to micropenis or a very small penis, or a patient with aphalia who was born without a penis. So in that way, in those three instances, you can see how ambiguous their external genitalia may be, and that is considered intersex. Second is a lack of responsivity to sex-related hormones. And the most common is androgen insensitivity syndrome. And I'm going to read a definition about that for you because I want to make sure I get it absolutely right. Formerly testicular feminization syndrome. And already there you can see the dichotomy, testicular and feminization, right? Is when a person who is genetically male, and by male I mean has one X chromosome, one Y chromosome, is resistant to male hormones, also known as androgens. And as a result, the person has some or all of the physical traits of a woman, but the genetic makeup of a man. Androgen insensitivity syndrome. So the androgen is there, the testosterone is there, the patient is just not responding to that. There's a lack of responsivity. And I just want to share with you, if you're interested in intersex care or learning a little bit more about it, androgen insensitivity syndrome showed up in Call the Midwife. Has anybody watched it before? Am I the only one? You've seen it before? Great. Call the Midwife is on PBS. It's a fantastic show. It's all about midwives. In season 8, episode 5, the character's name is Lois, who had androgen insensitivity syndrome. So if you'd like to learn a bit more about that, it's that rare pop culture moment when intersex is portrayed. Third is an inconsistency between external genitalia and reproductive organs. And there are a couple here. The first is 46XX intersex, which describes a female internal and virilization of external. Virilization meaning masculinization. So there's the difference between those two. It can be related to male hormones that are taken during pregnancy. And can anybody tell me when there might be a situation where someone's on male hormones and becomes pregnant?
Trans person.
There you go, trans folks, very good. So trans men who may be on testosterone who become pregnant could potentially lead to 46XX intersex. Not always, but I'm gonna put that out. The second inconsistency between external genitalia and reproductive organs is congenital adrenal hyperplasia. And congenital adrenal hyperplasia is when the adrenals, those walnut-sized organs that we have on top of our kidneys, secrete important hormones. And those hormones in congenital adrenal hyperplasia aren't being excreted because the adrenals are not fully formed. Male hormone producing tumors in the mother, or I should say in the parent, whomever is carrying the child, there will be male hormone producing tumors that can lead to an inconsistency between external genitalia and reproductive organs. Another is aromatase deficiency. I find this topic fascinating, aromatase. Aromatase is in all our bodies that is responsible for converting things like testosterone to estrogen. And I'll give you an example. So for trans men who take testosterone or T, if we treat with testosterone that is above the physiologic range for a cis male, the body, in an effort to create homeostasis, through aromatization, will convert it to estrogen. So we try not to put these high doses of T because it ends up being exactly the opposite effect than the patient wants. So that's something to think about. And that in aromatase deficiency means the enzyme that's responsible for that conversion is deficient. It is not there. And then the second inconsistency between external genitalia and reproductive organs is 46XY intersex. This, flip it around, male internal with ambiguous or female external genitalia. And this can be related to 5-alpha reductase deficiency. 5-alpha reductase deficiency is a little bit higher ed. I find it confusing as well, so I'm not going to spend too much time talking about that, but there you have it as an example. And then finally, I mentioned that there were four categories. The last is chromosomal variants, and some of these you may have heard of before. So 47XXY is Klinefelter syndrome. That's a male with an extra chromosome from either the father or mother. 45XO or 45X. So there are a couple of ideas, or excuse me, a couple of examples of chromosomal variants that can lead to intersex. So, how many intersex people are there? Does anybody want to take a guess? Let's say percentage, United States. What do you
I
think?
think I heard it's as many as redheaded people, but I don't know what that.
That'd be like
3%.
0.17.
I know, right? Great, let's dig in. I will reveal the answer. So, a Gallup poll, this was in, I believe, 2016, 2017, so it's a little bit older. Yeah, 2017. Shows that the percentage of LGBT folks, those who themselves personally identify as lesbian, gay, bisexual, or transgender, grew from 2012 at 3.5% to 2017 at 4.5%. Now, there are two problems with these statistics. One, it's self-reported. So there are plenty of folks who will not say, I'm lesbian, gay, bisexual, transgender, right? The second is intersex is nowhere in these statistics. It is poorly studied, or I should say at least not as robustly as studied as lesbian, gay, bisexual, and transgender studies. So that's something to think about. Those who publicly identify is also challenging because SOGI, or sexual orientation and gender identity information, does not catch those who are closeted, who are unwilling or unable to reveal their identities. A second, while I'm trying to drill down and get a little closer to percentage of intersex, the Williams Institute in 2016, Williams Institute being out of the UCLA School of Law, they used the behavioral risk factor surveillance system and determined that there were approximately 9 million LGBT Americans, population of New Jersey, if you will. 0.3% at that time identified as transgender. 1.8% of adults identified as bisexual. 3.4% of those assigned female at birth identified as lesbian or bisexual. And 3.6% of those who were assigned male at birth identified as gay or bisexual. Again, Williams Institute didn't focus on intersex. I realize it's not there, but I'm getting close. Hang tight. One other statistic came from Amnesty International. This was 2018. They estimate that intersex is about 1.7% of the worldwide population, and you're absolutely right. It is roughly the percentage of folks, roughly the percentage of folks that have red hair. And I think that's valuable information because for those who believe they've never seen or never met someone who's intersex, red hair stands out sometimes, right? When we're on the subway, when we're walking down the street, you see someone with red hair, you think, okay, not that they're intersex, but that there are just as many intersex people walking around as there are with red hair. So good on you, you got it. Roughly 18 million or 2 to 6%. Okay, let's talk a little bit more about the I in LGBTQIA+, or intersex. And a couple of questions just to begin. Why does intersex fit nicely into the LGBTQIA initialism? One is a shared experience of discrimination based on gender and biology, right? There's a kinship there. Understudied in medical and behavioral health research. I've already pointed out, intersex doesn't get studied as frequently as lesbian, gay, bisexual, transgender, and the LGBT folks don't get studied as frequently as those who are cisgender or heterosexual. People born with variations in sex characteristics have an increased likelihood of identifying as a sexual minority, so gay, lesbian, bisexual, pansexual, or queer, or and a gender minority, transgender, non-binary, or gender fluid. So there's actually an increase in the percentage of intersex folks who believe they are represented in the community. Cishet or cisgender heterosexual intersex people still identify as part of the LGBTQIA+ community based on common, marginalized, and or stigmatized experiences. So how do we recognize that a person is intersex? Anybody want to guess? When do we know it? How do we know it?
Puberty?
That's a great guess. Puberty. Excellent. Anybody else have thoughts? I'm an interactive speaker, sorry. I didn't mean to put you on the spot. All right. The first, during a prenatal ultrasound. Prenatal itself, I don't like that word. It's very problematic. I think you understand what I'm saying when I use the term prenatal. In an ultrasound, you may notice that there is a variation in sex characteristics. The second, at the time of birth, if genital variation is identified, so if a patient is born with aphalia, which I mentioned before, or clitoromegaly, it will be recognized generally at the time of birth. During care related to an inguinal mass or hernia that leads to the discovery of internal testes, so an incidental finding. Here's where you are, and you're absolutely right, at the time of puberty. So at puberty, if those changes do not occur, or if there's an unexpected physical change, and by that I mean virilization of those who are assigned female at birth. And then finally, incidentally, or actually no, I have two more. Incidentally, during a laparoscopy for another medical concern, so this is another incidental finding. And then finally, during evaluation of an adult for infertility, right? Why am I not able to have a child? Let's start exploring that, and suddenly we find that there is something else going on, and a patient becomes recognized as intersex. Let's talk a minute about cosmetic surgeries in the intersex community. Back in the 1950s, which is not terribly long ago, cosmetic surgeries were used to correct the appearance and function of atypical genitalia. They hoped to prevent the possibility of a child growing up to have non-heterosexual relationships, right? We want to keep folks on the straight and narrow, and this is one of the ways that they chose to do it. The majority of these are unnecessary cosmetic surgeries, right? We don't need them, there's no cause for them, but they were carried out in the 1950s and even more recently than that. These cosmetic surgeries come with adverse side effects, such as scarring, chronic pain, loss of sensation, urinary and sexual dysfunction, and or PTSD, depression, feelings of loneliness, fear of intimacy. Question for you. Can you think of some surgeries for intersex babies that might be medically necessary? Do they even exist? The answer is yes. Think back to what I mentioned before, aphalia. As an example, aphalia, missing a penis, maybe missing a urethra as well. We gotta take care of urinary output and worry about ramifications later. You gotta make a way for the child to pee. And in that way, it would be considered medically necessary. So cosmetic surgeries, surgery performed at an early age can assign a genital appearance that does not align with the individual's gender identity that emerges later. This is extremely important. No way of knowing when looking at a baby what they're going to turn into, right? And some folks, parents, endocrinologists, surgeons, were making that determination for them. You are going to be a woman when you grow up. You are going to be a man when you grow up. Awfully presumptuous of folks in that field. Surgery performed at an early age can assign, did I say that? I did, didn't I? No. Surgery performed at an early age can assign a genital appearance that does not align with the individual's gender identity that emerges later, and multiple human rights and medical professional societies denounce the act the act of cosmetic surgeries. And if you are interested, I did do a little Googling earlier today to try to find the name of the person who created the video, but there is an intersex activist who on YouTube, I believe, has put up a video of them as an adult confronting the surgeon who performed their intersex surgery as a child. And that is an example of a child who was assigned one thing, but grew to find that there was something very different. And it is a fascinating watch. So if you have the opportunity and you find it, you want to learn a little bit more about it, that would be one thing I would suggest. So let's talk about unnecessary and objectifying medical examinations. It happens in the intersex community. Oftentimes, intersex people are viewed as medical curiosities, right? There's something different here. Let's learn about it. And that itself leads to its own problems. Intrusive, objectifying, and medically unnecessary genital exams and photography as children. You'll see it in old textbooks. There'll be photos of genitalia of folks who are intersex. Imagine what that must feel like. You grow older and you find out these things are out there for public consumption. Medically necessary genital exams can re-traumatize an intersex patient. We're talking about an older intersex patient at this time. So it is upon us to establish a warm and respectful relationship, and I'll talk a little bit more in a moment about ways to improve your care of intersex people. Engage in shared decision-making, that would be with parents and also with child. We also recommend a trauma-informed approach, and I'm going to talk about trauma-informed care in a moment. Never expect a patient to serve as a teacher. It sounds like a simple thing. It can be challenging. I will tell you, in my practice, I've caught myself a couple of times. I don't really understand much about that. Could you please help me to understand? And I think I'm doing the right thing by trying to understand, but it's not the patient's job to teach me. It's my job as a clinician and as a provider to go and learn myself. Respect a patient's refusal to be observed by trainees. Not everyone likes to have a student in the room when they're being examined or even when they're being interviewed, and that may be the case in intersex patients. And again, never invite others without consent. And that's just in general, right? I don't ask anybody to come in the room unless I have cleared it with the patient that I'm working with. Now let's talk for a minute about non-disclosure. Non-disclosure is concealment of information for patients about their bodies. There is non-disclosure in the intersex community. The endocrinologist may say, shh, let's not talk about it. The surgeon may say, all right, I've done my job. I've corrected things and we don't really need to talk about that anymore. It may even be the parents who decide not to discuss it. Concealment of information from patients about their bodies. I try to put myself in that position, and I can't imagine becoming an adult and learning all of these things that have gone on heretofore. And there are great examples of intersex patients who have come across their medical records and learned an awful lot that they had not learned from their parents or from other healthcare professionals. It delays the process of self-acceptance and increases shame and stigma. Secrets always increase shame and stigma, but particularly in this community. Full disclosure is required so that patients and families can make informed decision. And I think what's really key about that bullet point is patients and families. We're not talking about serving the needs of just, and I'm using old terminology, just mom and dad. We're not talking about just patient. We're talking about bringing everybody together to make these decisions. Some common medical specialty care for for intersex folks would be steroid replacement. So for those folks who are missing certain steroids or androgens, or they have androgen insensitivity, we may need to replace that steroid. Gynecologic, urologic, and sexual health care. hormone therapy. Hormone therapy to induce secondary sex characteristics as desired. This goes back to puberty, which you mentioned before. Hormone therapy to affirm gender identity if the sex assigned at birth does not correspond with gender identity. Hormone therapy to replace sex hormones after surgical removal of the gonads. Anybody know why a child might have their gonads removed? Let's talk specifically about assigned male at birth and testes. No? Yeah.
No, never mind, go.
That's okay. I was going to say undescended testicles. There is a belief, or was a belief, and may still be, that a patient who is born assigned male at birth who has undescended testicles is at an increased risk for testicular cancer. That has since been debunked, and so we're choosing not to have that surgery. Common medical specialty care, prevention and treatment of osteoporosis. Osteoporosis, we know, is hormonally regulated. So if there's a hormonal imbalance for any reason, it could lead to osteoporosis. And then cancer surveillance. Now let's talk for a moment about a trauma-informed approach. I tend to try to think that every patient who comes into my office has been through some form of trauma. Every person I've ever met has been through some form of trauma. But it is particularly important for patients who are coming in for LGBTQ plus affirming care. Example, trans folks who have been flat out denied medical care. I know when they come in to see me, there's going to be a fair amount of medical mistrust. So I try to finesse that as best I can with trauma-informed care. As providers, we need to be aware that many patients have a history of trauma. I assert that every patient has a history of trauma. We need to understand the impact of trauma on health and behaviors. We need to recognize the signs of trauma. We need to access care for themselves to prevent secondary trauma and resist traumatization of the patient. And here, I'm going to give you an example. Recognizing that an intersex patient may experience a PAP as traumatizing. A pap smear, cervical cancer screening, also anal cancer screening, can be traumatizing for intersex patients. For that reason, we ask permission before performing the exam, and we can suggest an alternative. One alternative may be a self-swab. We can now do cervical cancer screening with a self-swab, and we offer that to resist the re-traumatization. I want to talk just a moment about inclusive communication. And this can be applied to the LGBTQI plus umbrella as a whole. Asking for sexual orientation, gender identity, and pronouns. We're getting better about that. It actually shows up now in electronic medical records. Has anybody seen Epic before? The electronic medical record, Epic? Okay. Epic, doing a much better job, but what I found really interesting is the SOGI section, the sexual orientation, gender identity section that shows up in Epic, the electronic medical record, that says the patient's pronouns are, the patient's legal name is, the patient's preferred name is actually a la carte. In other words, if you are working in a hospital who doesn't pay to have that extra little thing added at the top, you don't see it. So good on Epic for making that a possibility. We need to do better about making that available to every electronic medical record. We need to mirror terms used to describe themselves, their body parts, and their diagnoses. Using gender-inclusive language, and only ask questions relevant to current health needs. There's something called trans broken arm syndrome. If you'd like to learn a little bit more about relevance to current health needs, look up trans broken arm syndrome. I understand this is an intersex topic, but that is a terrific article. It talks a little bit about why do you need to know about my genitals if I come in with a broken arm? And they're always, not always, but in some medical settings, it seems that the focus is on the patient being trans, and for some reason that having to do with a broken arm when clearly it does And just to loop back for a second, gender inclusive language, using terms like, are you in a relationship versus do you have a boyfriend? Do you have a girlfriend? It may seem like common sense, but it is not always. Another, please remove your bra and panties is very different than please remove your undergarments. So that's something to think about too. One of the things that I adopted in my practice is sort of steering clear of PAP with patients that I take care of, and using the term cervical cancer screening, anal cancer screening, because PAP can be very triggering for some patients, specifically intersex patients. Ensure that communication is two-way, authentic, and active. Examine one's own biases, implicit and explicit. I want to share with you a tool. It's called the Addressing Model, ADDRESSING model. It was put together by Pamela Hayes, who is a clinical psychologist from the Pacific Northwest. It is excellent. You can Google it. It's pretty much open source. It has questions that will spur your mind to think very deeply about the things that you've been taught and uncover implicit biases. It's a terrific resource, and one that I hope that you will look into, because we all have implicit biases. P.S. They don't go away. The implicit biases will always be there. In my experience, the thing to do is to put those in a bag, throw it over your shoulder, and be better. Go into the patient's room and not function from those implicit biases, but function from a place of caring and inclusive care. One's own biases related to gender identity, gender expression, and anatomy. And then we want to participate in LGBTQIA+ affirming healthcare training sessions. You can find that through Fenway Health. I keep coming back to Fenway Health because they're a fantastic organization. They have a lot to offer. And there you can participate in that certain healthcare training. Current health needs. This came up in my studies, asking oneself the questions, what do I know? What more do I need to know to treat this patient? And how can I ask for the information I need to know in a sensitive way? Not always the easiest thing to do, but we want to try and find a sensitive way to collect the information that we need. I go back to the example of the PAP. A little bit more sensitive to say, cervical cancer screening, anal cancer screening, to collect that information in a sensitive way. I also want to talk about a cultural humility approach. Remaining aware of the impact of trauma on the patient's ability to engage with medical providers. Acknowledging the potential hardship of failing to find specialists in intersex affirming care. It's not always easy to find specialists in intersex care. Emphasizing the comprehensive informed consent, speaking specifically about surgeries and also hormonal replacement if necessary. Do not assume that clinical training makes one an expert in the lived experience of an intersex person. I've learned a little bit about intersex. I have taken it upon myself to teach myself. It does not mean the patient who sits across from me fits into any particular box, right? They have a completely different lived experience than what I might have learned. So just going in there humble, right, to learn. Respecting the patient's and family's right to refuse examination, observation, or treatment. We all have that right, but specifically in the intersex community. Including observation by trainees when the primary purpose is educational. If you're bringing folks into the room just so that they learn, now I get it. We have to learn somewhere. That makes sense, right? In medical schools, at nursing schools, here at Pacific, we need to be in with patients to learn. But when education is the sole focus, it's probably not the best time to take advantage of an encounter with a patient. And then accessing current literature and continuing education opportunities on intersex health. You're doing it right now. Good on you for coming in and spending some time today to learn a little bit more about the topic. I want to share for a few moments intersex infants, children, and their families. Discuss that intersex experience is more common than people think. So what I'm referring to here is, let's say you're a nurse. You could be a massage therapist. You can be an acupuncturist, right? And be caring for patients who are intersex, right? And we need to recognize that it's more common than we may think. It would be helpful, or can be helpful, for parents to learn your child is not the only intersex human being on the planet, right? Recognize that families may have experienced medical trauma during or immediately after the delivery of their child. So, the birthing parent may see an ambiguous genitalia and feel that that's traumatic, or have a trauma experience. So that's something to think about. Stay positive about the child's health and future happiness, right? Intersex is not a curse. It is not a sentence. We can lead long and happy and healthy lives. Do not be overly focused on the child's intersex features or genital appearance, but also do not avoid discussion of intersex characteristics altogether. So don't pretend it's not happening. That is a disservice both to the patient and to the family. At the same time, don't make that your sole focus. There is so much more to this human being than their genitals or chromosomes or gonads. And then ask what pronouns to use. Use gender inclusive, such as your baby or child, if pronouns are not yet chosen. Parents may not determine yet if they're going to use he, she, they, them, whatever their choice is. So for us, it's your baby or your child until those pronouns have been chosen. Do not choose a pronoun for the child and never use it. I know that sounds like common sense, but it needs to be said. Choosing a pronoun for the child is completely inappropriate. That should come from parent, and then once that child is older, they get to assert who they are. Assist families in finding and interacting with intersex affirming specialists. Those include pediatric endocrinologists, they do exist, and behavioral health professionals. So trying to help the family get plugged into the care that they deserve, that they need, that affirming care. Support families in their decision to refuse medically unnecessary surgeries until the child is mature enough to provide fully informed consent. Help families access peer support. There is peer support available. The Intersex Society of North America, I mentioned before, is a place where families can find peer support. Recognizing that gender assignment is provisional, and do not assume the child's gender expression will align with societal gender norms, but also do not assume it will not. In the next 3 or 4 slides, I just want to point out the pictures that we have here. They're from Teen Vogue, and they're all self-identified intersex persons, and I wanted to use that for the presentation. Intersex adolescence through adulthood. We talked about infants, babies. Let's talk about adolescence through adulthood. Anticipate the potential for strong emotional reactions if an adolescent's body does not develop as anticipated at puberty. You can imagine how alarming it might be if, I'll use myself as an example, when I was 13, 14 and my voice was starting to change, and I saw other folks whose voices were starting to change. If there was someone in the circle of friends whose voice was not changing, didn't change, that could be, they may feel pulled apart from their peers. Recognize that due to medical trauma, intersex youth are more likely to distrust medical providers. Medical mistrust is huge, not only in this community. They're more likely to miss appointments, not show up for their appointments, and question medications. Can you tell me why you're prescribing this for me? Let me learn a little bit more about that. Those are features that you may notice in intersex youth. Acknowledge that patients may feel anxiety if it's their first visit without a guardian. So we know that in adolescence, folks start visiting their providers on their own, and to be without a guardian, it's very anxiety producing for that group. And be mindful that in some families, parents almost always accompany their adolescents and young adult children. So while some folks are beginning to see providers on their own, there are others whose culture within the family is that the family sticks together all the way through adolescence and into adulthood. So It always defaults for me to the patient. Would you like your parents to come in? If they want their parents to come in, their parents come in. Would you like your parents to come in? I really don't want my mom and dad in here. So, no, we're going to leave your parents in the waiting room. Encourage patients to be curious about their bodies. Explain that a wide range of sexual activity is normal and enjoyable. Do not assume the patient desires to have heterosexual relationships. We should be not assuming that about any of our patients. Promote patient-driven goals regarding gender-affirming care. And if a patient is concerned about confidentiality, explain why the information is relevant. Like, why am I asking you these questions anyway? Explain how medical information is kept confidential to the extent of the law. And do not convey the message that information regarding sex characteristics is inherently shameful and should be hidden from others. Again, I know a lot of this sounds like common sense, but I want to put it out there. Do not assume a patient menstruates, right? If you have a female appearing patient who comes in your office, age 16, 17, don't assume. You don't necessarily ask about periods. Discuss fertility preservation with patients who may be interested in having biological children. Recognize that fertility options for some intersex patients may be less available than options for non-intersex patients, and acknowledge other available family building options, adoption, etc. And screen for anxiety, depression, substance use, and suicidal ideation. Refer to intersex affirming behavioral health care, peer support groups, and other resources as needed. I mentioned referring patients out. So just a couple of points for best practice. Number one, mirror the terms that your patients use. Your patients are going to tell you what they're comfortable using. So listen to what they're saying through their speech and mirror that. And ask them what they prefer at the onset of the clinical relationship. What pronouns do you, and it really shouldn't even say prefer, and I'll take that out for the next presentation, but ask them what their pronouns are. Just to let you know, we have Intersex Awareness Day. It's on the 26th of October. So that's something to look forward to. And I now have a couple of questions for you. A little discussion question or two. The first, if 1.7% of people in the United States are believed to be intersex, the number of redheads, approximately 5 times the number of transgender people, why don't we hear more about intersex people in the media, in school, and in medicine? Think about it. We're hearing a lot about trans folks right now in a negative light. They're trying to do away with gender affirming care in certain states here in the United States. But if there is this number of trans folks compared to this number of intersex, why are we only hearing about these folks? Do you have any thoughts?
I mean, I have a lot of thoughts. I just feel like transgender people are like way more easily vilified because it feels like a choice. And also, just based on what you said, like I feel like a lot of intersex people maybe don't even know that they're intersex, or like there might not be anything. It feels like weird and rude to say, but like you don't know about it. It's not like seen or heard.
I don't think that's weird or rude at all. It's absolutely the truth. You can look at a person who's intersex and not know and not assume. And for that reason, they may not be depicted as frequently in media, in school, and in medicine. That's the reason I wanted to point out Call the Midwife. It's that rare moment, and I know I mentioned this before, that rare moment in pop culture where they really delved into intersex and the struggles that intersex patients go through. So, second question for you. Intersex information is often excluded from LGBTQ+ resources. Do you believe it should be included? Why or why not? There are a couple of great books out there about queer health that don't include intersex whatsoever. Should it be included? What are your thoughts?
I mean, if it's under the umbrella, I would.
Yeah, if it's under the umbrella, put it
It's
in
like,
there.
where do I research to, find these like literature based on like, I would include it.
Yeah.
Yeah.
Yeah. And most frequently it is included. But as I said, there are a couple of resources out there that just don't seem to go there, for what that's worth. And now I leave it in your capable hands. What questions do you have for me? If any. And then I'll wrap it up.
Maybe question and comments.
Yeah, certainly. Comments, questions, complaints, whatever you got. Bring it.
I feel like I have there's like a lot turning over in my mind, but I don't know what it would be yet.
I'm pleased to hear that a lot is turning over in the mind. That's wonderful. That's the whole point of having these discussions, right? To expand our consciousness surrounding a particular topic. So I take that as a compliment.
I really love that we don't expect, much less demand, our patients to spend that emotional energy to teach us. And I think that's very useful.
Mm-hmm.
And if we want to learn something, spend the energy to learn it, and rather than expect or demand the patient to go through that emotional burden, emotional energy that they have been experiencing, and then go through that again to teach what we don't know.
Mm-hmm.
I guess, sorry.
No, please go ahead.
When you were bringing up Epic and how, if you pay a little, can have it included in medical charts, right? Like how, because we use different platforms here, and then there's other places that use EMR and just different systems. Like, how can we try to get, them on our systems? Because it would be nice to be inclusive and just not have to, you make them feel uncomfortable in any way.
And one way to go about that is to get plugged into the EDI committee and make that change, inform that change here at Pacific or in wherever you may be practicing.
Mm-hmm.
It's incumbent upon us. Yeah.
Do you have strategies that either you use or that people use to how would I word it? Soft open or softly ask about the more sensitive topics, but that are actually relevant to what someone might be coming in for? Because I just struggle with that in my own experience of, what did you call it? I left it. Trans broken arm syndrome.
Mm-hmm.
Never heard that before. I've definitely had that experience.
Mm-hmm.
But yeah, I often, even here, even in the clinic, and I'm comfortable with everybody here, but I'm immediately antagonized by some of the questions. I'm just why are you asking me that? But then I'm I know you're asking me that.
Yeah.
But it just feels can someone knock on the door before they open it? It kind of feels like the door just gets flung open, and then there's questions, and I don't.
Yeah.
It's odd.
You answered your own question. It's a very, very, very good question, and the answer for me is exactly what you said, which is knock on the door before you open it. And one technique that I use is just being open and honest with our patients to say, or with our clients. I apologize, I don't know what terminology we use at Pacific. I've been using patients because that's what I do.
Mm-hmm.
Knocking on the door. So I'm going to ask you some questions that might make you feel uncomfortable. Know that it feels a little anxiety producing for me too, but we'll get through it together. It's a simple way to open up a conversation that disarms the patient and also gives some space for the provider to take a good deep breath, admit you don't know everything, and make yourself open to whatever the patient's going to tell you. Does that help to answer your question?
Yeah. Yeah, I guess I was wondering if there's specific, almost scripted, I like how you were referring to the cervical cancer screening, that's just a term you could go to.
Yeah.
To replace certain things.
Couple of things I would say. Yes, cervical cancer screening is a good example. A big help is what a patient may see before they ever get in the room.
Mm-hmm.
So if you are as many of us have done, going to your medical provider and they hand you a form that you have to fill out before you go in. If intersex is on that form, we've already knocked on the door. By the time the patient gets in, they realize, okay, I can take a deep breath. They know something about intersex, otherwise they wouldn't have put it on the form, and I can feel comfortable being here. So that might be one other way. If you were the head of a practice, or not even the head of a practice, someone practicing within that practice who could say to whomever is the head, hey, we need to do a better job of representing on these forms that we're handing to patients before they ever get in the room. So that's another I might consider. Full disclosure, my experience, my conscious experience of care for intersex patients is limited. I've only ever had 2 patients in my 11-year career who have self-identified as intersex. Of course, I've taken many more intersex patients into my office, absolutely. But for reasons that are unexplained, there were only 2 who felt the need or felt comfortable to disclose themselves. So I haven't had a lot of experience trying to open up these conversations, but I can tell you from my experience, not simply with intersex folks, but with folks in general, just being open and honest about what you don't know. This might be a sticky topic. I apologize if it feels uncomfortable. Please know that I'm a little anxious as well. And then if you go into that topic, you're on good footing. It helps. It sort of takes the heat off of you. What else you got? Excellent questions and comments. I appreciate it very much. It is an open door policy. I will give my information to Ray. So if you have questions that crop up after the fact, please email me. I'd be happy to share with you, and I'll give it to you now. Actually, it's my initials, JD, 1824 at nyu.edu. JD1824 at nyu.edu.
Do you teach continuing education classes?
No, I don't. That's a great question, and it's one that I've considered. I just don't have enough hours in the day
I get it.
to make it happen. Between working full-time at Callan Lord and then also teaching the course at NYU and having a personal life on top of all of that, it is challenging. It's interesting that you brought that up. One of the things that has come up recently, I was just on a call-in show on SiriusXM, the nurse practitioner show with Eileen Sullivan Marks, and she was suggesting putting together a credential in LGBTQ plus care for nurse practitioners, but that could translate into any field. It might be something that you would think about if it's a topic that is particularly passionate or that you are particularly passionate about. You can make that happen.
Do you, in your professional experience, see people moving away from LGBTQIA and stacking letters on top of it and moving into calling it GSM? Or is that like a chronically online take that I have?
Gender and sexual minority.
Yeah.
I do hear GSM, and it's a little bit tricky. GSM is more often used in research. You see it a lot in data. You see it a lot in articles, GSM. I don't see it in clinical practice. What I'm seeing more than moving toward GSM is moving toward queer, just using queer as an umbrella term for those folks who come in seeking care. So in that way, the nomenclature is changing, but I don't see it moving toward GSM.
Okay, thank you, Jeff.
Of
And
course.